program educating many of us. All right, today's speaker is Dr. Caitlin Anderson. She's a pediatric psychologist and assistant professor of pediatrics within the University of Virginia School of Medicine, Division of Neurodevelopmental and Behavioral Pediatrics. She completed her bachelor's degree in psychology at Wake Forest University, her doctorate in clinical psychology from the University of Southern Alabama, and an integrated internship in primary care at University of Oklahoma Health Science Center. She completed a 1-year postdoctorate fellowship in pediatric psychology at Oklahoma Children's. Dr. Anderson specializes in working with children and families facing chronic illness, challenging behaviors, anxiety, depression, and neurodevelopmental differences. She has extensive training in cognitive behavioral therapy, parent-child interaction therapy, behavioral management, and trauma-informed care. Dr. Anderson is passionate about integration of mental health services in pediatric primary care, universal screening practices, and increasing access to high-quality, evidence-based mental health services. She recently joined the Virginia Mental Health Access Program, VMAP, team as a licensed mental health provider for the Western region. Please join me in welcoming Dr. Caitlin Anderson.
Thank you all for having me. It's so nice to be presenting to like actual people as well as a screen. It's nice to be in the same physical space as people. So thank you for the opportunity to talk with you all about VMAP. I know Dr. Kreider has been working hard to educate and inform people about VMAP and all of the wonderful services that are available to you all. So hopefully I can just tell you a bit more about some of the pieces and how it works and answer any questions that you have about VMAP. I will say, I'm relatively new to VMAP. I started, I guess, in January, so it took a little while to get going. And so if you ask me a question about something and I don't know the answer to it, I promise I will get the answer and I will get back to you. If you use VMAP services and have feedback or recommendations for how it could be better, please email me, tell Dr. Kreider, we can get the message to the right people. I think a lot of these services were brought about by good ideas, and things we're continuing to do are generated by people's ideas. So please reach out if you have feedback or suggestions for how this could be improved, because we're here to support you. At the end of the day, this is a service that is designed to make your lives a little easier, and that's really the goal. So I'm going to be talking a little bit about sort of the current landscape of mental health care, pediatric mental health care in our state and in the country, and how people are trying to address that and the shortage of mental health services through things like integrated models and access programs such as VMAP. Disclosures, I'm involved with VMAP. I guess prior to January, I was full-time with UVA Children's. I primarily provide clinical services, outpatient therapy services to patients and families within our developmental and behavioral clinic. And then starting in January, VMAP sort of bought half my time. And so I do outreach and consultation services with VMAP half-time. Other half of my time is still spent providing clinical services at UVA. Just to give you a little bit more kind of context of my background and how I got here, I'm originally from Southwest Virginia, a very small town called Independence, Virginia. Galax, Virginia.
And guess what? Independence is where I went to school.
That's amazing.
Okay, we're talking. I honestly thought this was only webcast, so I was like, oh, I don't need, but I was here. And then I saw that you were in this room. I'm like, I gotta go to the meter. Sorry.
It's always nice to know someone who's even heard of the town.
Absolutely.
From the area.
Yeah.
So that's great. Yeah, so that's where I'm from. I completed undergrad at Wake Forest and then worked for a couple of years down there. Completed my graduate training at the University of South Alabama in Mobile. A big part of my research and clinical work during grad school was really sort of focused on integrating mental health services into primary care settings. A lot of those settings I worked in were federally qualified health centers. And then that sort of sparked my interest in kind of pursuing that further. And so I completed an internship at the University of Oklahoma Health Sciences Center It was a HRSA-funded track, and it was really focused on providing integrated services for underserved populations. I stayed at OU and completed a postdoc fellowship in pediatric psychology. So I provided mental health services within peds primary care, but also endocrinology, HEMONC, and a pediatric weight management clinic. And then I came back to Virginia and have been at UVA for about 2 years now. Like I said, I've been involved with VMAP for 5-6 months or so now. So today we're going to just sort of talk a little bit about the major barriers that exist to pediatric mental health services. I know that you're all aware of the crisis. Dr. Kreider has talked at great rounds previously about sort of the landscape and the scope of the problem and the youth mental health crisis. We're going to talk about integrated care and the value that it brings to the picture. We're also going to talk about the challenges and the barriers to that. And I want to spend the bulk of my time today really kind of diving in on the services offered through VMAP and how to access them and what that process looks like for you. We also want to talk a little bit about how VMAP can be helpful not only for primary care providers, but also pediatric subspecialists. I know at UVA there's been a lot of interest of how subspecialists can sort of access VMAP services and what's available to those providers as well. So I want to mention that too. So again, we're all aware, I don't need to go into great detail here about the current youth mental health crisis. We all know it exists. It was there prior to the pandemic, and then post-pandemic, it's even worse. And so, you can't turn on the TV or read an article or open a newspaper without seeing a headline related to this. And as I'm sure you're all navigating, I'm navigating this as well. There are so many barriers facing providers, families, children looking for mental health services. A lot of those barriers are, system level barriers that exist. A lot of those might be more sort of individual level. The workforce shortage is a big one. We'll sort of talk more in depth about that one here in a little bit. But there aren't enough services, there aren't enough providers out there. And a barrier that will always exist for families are sort of the resource cost related barriers that exist. I think telemedicine has helped with some of that, but has not eliminated the problem because a lot of the families who sort of face the cost related barriers may not have access to great Wi-Fi or internet services. Inconvenient service times. A lot of mental health clinics operate business hours, 8 to 5, 9 to 5. Parents work during that time, kids are in school, so it can be really challenging for families to take off work to attend weekly therapy appointments. I think a lot of families really seek out evening hours or weekend hours, and I think that is a way to sort of combat this one, but then providers have to work weekends and evenings, so it's really challenging to kind of balance that. I think a big one oftentimes is just the amount of advocacy and persistence it takes from a parent or a family to find services. You have to know who to call, who to ask, how to ask, what to ask for. It is exhausting. I've talked to a lot of mental health providers and psychologists I work with who have been navigating this for their own kids. And even providers who know the questions to ask and know where to go. It's hard. It is really challenging. And a lot of kids don't have that level of support to really fight the system like that. There are so many complex pathways that exist. I know, I've referred kids that I've seen to community service boards for services. And they come back to me and they say, well, we went and we were told we don't qualify for services. I'm like, no, that's not right. Go back and ask for this specific thing. And they go and they're able to get that. But unless, again, you know who to ask and what to ask for, it's really difficult. Insurance is, of course, a barrier. A lot of places are self-pay only, or only take Medicaid, or only take private insurance, and so trying to navigate that's a challenge. I think the stigma barrier is one that's maybe getting a bit better over recent years, but it still exists. I think there still is a stigma attached to asking for help and accessing mental health services. Previous negative experiences with the mental health system, especially in the way it exists today. I think a lot of families have negative experiences with mental health providers, whether that is not receiving evidence-based care and not seeing results, whether that is lack of communication on behalf of the provider. A lot of families sort of experience that and have kind of a bad taste in their mouths when it comes to mental health care. And so trying to navigate that's a challenge as well. I think it really does feel like an obstacle course for families sometimes trying to find services, and an obstacle course for providers when we're trying to find services for our patients as well. So we just want to talk about the workforce shortage for a second, and sort of think about the state of Virginia. Virginia ranks the 41st lowest for the number of mental health providers per population. So we're not doing great when it comes to that. And I think even more startling is the fact that, especially kind of the psychiatrist numbers, a lot of psychiatrists in Virginia are approaching retirement age. And there are not enough trainees kind of coming in to fill that. So unless something is done and changed, this is not going to be a problem that's fixed anytime soon. There's also significant staff shortages within community service boards, within state hospitals. People are overworked, underpaid, they're put in, positions that are safety risks, and people just don't want to work there. I do know, I think last year, the Department of Behavioral Health and Developmental Services sort of directed some emergency funding to state hospitals trying to provide bonuses, incentive for people to stay. But then what they found ended up happening is people from the nearby CSBs ended up leaving the CSBs to go to the state hospitals. So it didn't necessarily do what they intended it to do, but the creative way of thinking about it and how can we sort of get people to stay and to want to work in these settings because they are so important. So you all are feeling this, right? Like you are feeling the shortage, you're feeling the barriers. This is Virginia American Academy of Pediatrics survey data from 2020. And essentially this is just saying like help. Like we don't have enough resources to help our patients. We can't find mental health providers when we need them. We can't find consultation with a psychiatrist when we need it. And just needing that support. So what do we do? And there is ongoing conversation, efforts, advocacy work that's going on currently to try to address this. It's not an easy feat, as you know and can imagine. But there are a couple of options for how to tackle this. And I think one of those is expanding the mental health workforce. And how do we do that? We can increase funding for psychiatric residencies. Trying to find incentives to keep graduates in the state of Virginia, workforce development programs. One big barrier for master's level mental health providers is the fact that after training, a lot of them have to pay significant fees for supervision, talking like $10,000 sometimes for supervision that they're having to pay for. And so these graduates are finishing school and then are expected to find this money to pay for supervision. And so programs that sort of help provide assistance in paying that could be helpful. I think especially for trainees or master's level providers from underrepresented groups or those who are hoping to sort of work in more underserved areas such as independence and freeze and GALACs, right? Like trying to provide some incentive and assistance for those trainees. So expanding the workforce, more providers would be great, but also increasing access to services is an option as well. I think telemedicine, that's been sort of one positive thing I think that's come from the pandemic, and sort of being able to reach families who may otherwise not have been able to access care. Really sort of enhancing insurance coverage and reimbursement, and sort of equalizing that across insurance companies I think is a big one. Programs that allow psychologists and mental health providers to practice across state lines can help with some of this. Many families live right on the state line, right? And they might be much closer to places in Tennessee or North Carolina or Maryland. And so having that ability to seek care outside of the state is also sort of a way to increase access to services. Integrated care is another one. If you didn't know, I'm very passionate about integrated care. That's really what I enjoy doing. I think there are so many benefits of that, but also a lot of barriers, which we'll talk about as well. And then, of course, access programs are another way to just increase the ability for providers and families to access providers that are already out there. And of course, that's what I'm going to spend the bulk of my time talking about today. We honestly need just an overhaul of the health system. At the end of the day is sort of what we need. You know, emergency rooms need to be redesigned to support providers and families. We need to have people trained in crisis spaces and emergency departments designed for that. So no big deal. We just need to totally redesign the entire health system. So again, integrated care is something I'm really passionate about and really enjoy providing, and where I spent a lot of my training and research efforts. I'm really passionate about sort of universal screening procedures and making sure that we're sort of addressing things in the family's medical home. You know, you guys are the ones that they trust. You are their people. And so sort of capitalizing on that relationship, I think is really valuable. So integrated care really is the provision of mental and behavioral health services alongside medical providers in a shared space in the same system, right? So like just right down the hall, a couple doors down, everyone's there together. And having that behavioral health care and mental health care available for all patients. It's just part of a patient's treatment. It's part of prevention, right? It's just everything is there. We're talking about their physical health. We're talking about their mental health, and sort of addressing everything all at once. And having sort of behavioral health providers available for consultation and intervention sort of on the spot in an ideal world. Again, lots of barriers to that, which we'll get to. But sort of having that integrated treatment plan where everyone's working together to make sure that patients' needs are being met. If we kind of think about different levels of integration or care, you know, there's coordinated care, which I think a lot, if not most people are doing, where, you know, we're trying to coordinate and communicate with people across systems. We all know the difficulty of that. Care can be co-located, where maybe you're in the same system, but everyone's sort of in their own little world, doing their own treatment plan, and working on their own goals without that real true integration and collaboration. Of course, goes all the way to being truly integrated, where everyone is, I love like a workroom with everybody in the same space, where you can just go grab somebody if you have a question, or if you have a patient that wants to talk with behavioral health, or if you have a question about medication or a question about treatment, just everyone being there to have that conversation together. Behavioral health providers in primary care clinics can do a variety of things. And you know, as a mental health provider who's worked in primary care, I think sometimes people just don't know what behavioral health providers do, right? They think therapy. But they're not really aware of all of the different types of services that we can assist with and help with. You know, things like implementing screening procedures or sort of prevention efforts. I think prevention is a huge one. I think that could also kind of tie back to how can we address the shortage. I think if we stop taking this like crisis approach to mental health care, which is historically what this country has done, how do we address the crisis versus how do we prevent the crisis? I don't know if you all are familiar with Healthy Steps program, but having developmental specialists embedded in a primary care clinic who can talk with families and screen for developmental concerns and provide guidance and recommendations. I love those types of things. Like let's prevent the crisis from happening. But also, you know, they can be available for collaboration and consultation, focusing on health behaviors, you know, trying to get people engaged in positive health behaviors. Patient and family engagement, how can we sort of motivate the family to engage more in treatment goals, care coordination, of course, brief treatment of mental health concerns, so sort of brief evidence-based treatment of things like depression or anxiety or disruptive behavior, as well as other things that they can do too. But if we just sort of compare traditional mental health to integrated primary care services, what really makes integrated primary care different is, again, that services are provided in the same office space as their medical services. So that could be same day as a medical appointment, but it's in a space that they're familiar with and comfortable with. Services are often offered in real time. Again, like in an ideal model, behavioral health providers are available for, it's called a warm handoff, where the primary care provider goes and gets the mental health provider, and they go in together and sort of introduce and sort of facilitate that process. Everyone's working together on that interdisciplinary team versus those silos that everyone's having to try to communicate between. And again, I think integrated primary care really offers the opportunity for more of that prevention and early intervention. We can do things early on. Traditional mental health is typically sort of longer term treatment, and a lot of patients need that. Some patients really need sort of longer term treatment, more sessions, more time, whereas a lot of kids and families can really benefit from 2 to 4 sessions providing evidence-based treatment for concerns. And so that's always an option in the integrated care setting as well. Barriers. There are always barriers to things. Things are always really good in theory, and then the reality of it always presents some challenges. But I think time, is a big one. And you all are acutely aware of this. I know of how, packed your schedules are, and integrated services, they take time. It takes time to go grab a provider and introduce and facilitate that. It takes time to communicate. There's, again, like integrated primary care still requires the pediatrician or the primary care provider or the subspecialist, because these services can be integrated into those clinics as well. But it requires some level of comfort with mental health concerns. You still have to be, trained and be willing to have those conversations. And there's a lack of that availability. Reimbursement concerns, I think, are a really big one. How do we bill for this? We don't want families paying 2 co-pays to see 2 providers in a day. We don't want families receiving a surprise bill for a warm handoff that they received. I think there are states that are doing some really cool things when it comes to this. It'll be interesting to see the effects of that and how that sort of trickles to other states as well. The workforce shortage and the lack of community resources is another barrier. This is one that I continually face in Charlottesville and at UVA, and kind of advocating for integrated care is, again, in that integrated care model, we're not seeing patients long-term. We're referring those patients if they need it. And if there aren't places to refer to, then the integrated care providers get backed up, and they're not really doing what they're intended to do. Also, again, the resource and cost barriers exist for this service as well. So how can VMAP help with this? What can VMAP do? What are the things that can be helpful for all of you to think about and consider as you think about using VMAP? So VMAP is not a solution to the shortage, right? VMAP is not providing additional providers. They're not training more providers to put out there, but VMAP is sort of giving more keys to you all to access what's already there. So I kind of think of it as sort of a door for services, and there are multiple keys to get there, and VMAP sort of is facilitating that. And so helps you all access services, helps family access services that exist, but also the training and education piece, I think, is a big one. I know that's one that Dr. Kreider has talked with you all about, so I won't spend the bulk of my time today on that piece, but that one is a really big one. VMAP is not the first access program. There are many access programs across the country. Most states have an access program of some type. Now, what that looks like varies from state to state. What they provide varies from state to state. But keep in mind, like, the majority of states do have a program like VMAP. Just to orient you a little bit to VMAP and what it looks like. So VMAP is a statewide, state-funded program. The Western hub is the orange, and it's really big. And that's the one we're in, all the way Winchester to Danville. So a big area geographically. But the Western hub is the last hub to get up and running. So now that the Western region is going, the whole state is covered. We are still in the process of hiring providers and mental health consultants and care navigators for our region. So right now, and again, I'm based out of UVA, and I'm half-time with VMAP, and I provide, again, the consultation and outreach services, but we're looking to hire another half-time person for that to sort of round that out. And then I guess 2 or 3 weeks ago, we hired our care navigator for the Western region. And for the Western region, UVA and Centra are sort of collaborating together to be the hubs for this region. And they're in the process of hiring providers as well. So soon, we will be fully up and going, which I think will be really helpful. In the meantime, you know, if you call during a time where I'm not with VMAP, the other regions are sort of helping each other out and manning the consult line. So just because I'm only half-time, the services are available to you full-time. It just may be someone from the northern region or the eastern region that answers the call. So you can kind of think about VMAP as having two branches. The first branch is education, and we'll talk a little bit about this in a second, but again, I'm not going to spend too much time there because Dr. Kreider is the expert on this piece, but there are some really great education opportunities that are part of this. And the other branch of that are the regional hub services. So again, every region has a licensed mental health provider, such as myself, or a social worker who's available to provide consultation. There are psychiatrists available to do consultation, and then we have care navigators as well. And we'll talk in detail about what each of these things means and what you're able to get with each of those. The consult line is available Monday through Friday, 9 to 5, really 9 to 4:30 if you get technical. And so just be aware of that too. And services are available for patients 21 and under. So the education, there are many great opportunities for education. The REACH Institute, or the REACH program, which Dr. Kreider really takes the lead on, is a wonderful, wonderful program. I had the opportunity to just sit in on one of those sessions, and it was really great. It was interactive, it's meaningful. I learned a lot just being in that myself. And so I would strongly encourage, if you haven't done a REACH, do a REACH. And it's much cheaper to do REACH through VMAP. It's what, like $100 through VMAP versus like thousands of dollars outside of $2,600 if you don't do it through VMAP. So take advantage of that. It's a big difference. We also have Project ECHO, which I am faculty in the Western ECHO, and that is sort of a year-long program with monthly didactic and case discussion. So each month is a different topic, so things like anxiety, depression, trauma, PTSD, and sort of do half or 75% of the session is a didactic, and then a case discussion where everyone gives feedback and talks about kind of recommendations and options for a real case. And then there are QI opportunities as well. So these numbers are up to end of March of this year, so they're probably a bit higher now, but as of March 31st of this year, 734 providers across the state had registered for VMAP. Over 2,000 consults have been provided, and almost 15,000 hours of training have been given. So just to sort of give you an idea, and raise your hand in the room if you have called the VMAP consult line. Okay. So the idea behind VMAP and the way that it's intended to work is that, you know, providers would be engaging in some piece of the education, right? Maybe they attend a REACH, maybe they're participating in ECHO, maybe they're just reading through the guidebook that recently came out, which we'll talk about. Maybe they're just doing some education on their own with the guidebook. But in some way, there should be this education piece happening. And then as a result of that, maybe the provider's becoming more aware of mental health concerns in their practice, or they're more comfortable asking about these things or screening for these things. So concerns are coming up. if you're not asking them, I guarantee they're still coming up. And so the consult line is available, again, Monday through Friday, 9 to 5. So you would call the consult line. Someone would pick up. That would either be myself, another mental health consultant across the state, or one of our care navigators. We would gather information from you. We would ask some information about the patient that you're seeing. We would ask information about the visit, about you, get your contact information. I think feedback I've gotten to this point has been like, it's longer than providers would like it to be. A lot of questions are asked, and I get that. If you register for VMAP, we'll have to ask you fewer questions because we'll have some of your information in our system. So that'll cut down a little bit on the time and all the questions. But a lot of the questions we're asking for a reason. A lot of it's coming from the powers that be, sort of collecting data on VMAP and the services being provided and what's helpful and what's needed in the future. So a lot of it is just, we have to ask that. And I get the frustration with that. I know it feels like it takes some time, but it gets faster. And again, register so we don't have to ask like your MPI and your phone number and your email address. We'll already have that stuff. But you would call, talk to someone for the intake. And then based on what your question is or based on what your need is, we would sort of route that to the appropriate place. And the options again for that would be a psychiatry consult with a child and adolescent psychiatrist, a child psychology consult with myself or another provider, or care navigation. And you can get all three of those. You can get any combination of that, or if you just want one of them, that's okay too. But based on what you're needing, we'll sort of route that to the appropriate place. Okay, so if you call the consult line and you are needing a consultation with one of our psychiatrists, what we would do is we'd get your information. I would pass that along to our psychiatrist who is on call, and you would get a call back within 30 minutes to sort of talk that case through and get recommendations from them. I also recognize that that's not how your schedules work sometimes. You may not be available 10 minutes from now or 30 minutes from now. And so if there's a time that works better for you, you can let that intake person know, hey, I'm not available in the next 30 minutes, but I have an empty space between 2 and 2:30 today, if they could call during that time. And we can do it that way. We can kind of work with your schedules and do what makes sense for you. But based on what you tell us, the psychiatrist would give you a call within that time frame. And our psychiatrist can provide recommendations and assistance around just kind of talking a case through, providing sort of assistance with diagnosis or case conceptualization. If you have prescribing questions, maybe a kid's been on something for a while and it doesn't really seem to be working, or they had side effects from that, and you're not really sure what to do next, you can call the psychiatrist and they can kind of walk you through it and give you some next steps to help with that. And then the notes from that consult would be emailed to you, the provider, within 2 business days. So you would sort of have a summary of what you talked about, what the recommendations were. That way, you have that record, and you can put it in the patient's chart, document that as needed. If you want a consultation with me or one of our licensed mental health providers, if you get lucky and you call the consult line and the intake is with one of us, we can just do that while you're on the phone. It wouldn't need to be a callback situation. We could just take care of that while we're talking. If it's the care navigator who answers the phone, it would work similarly to the psychiatry consult, where the care navigator would send me a message and say, hey, this provider wants you to call them back during this time. I would do that. And our LMHPs, as we call them, can help with a variety of things. So we can sort of, again, talk through a case with you. We can sort of provide some guidance with diagnostic considerations. Level of care referrals, I think, are a big one that we get calls for, just sort of talking through, like, what is it that a patient needs? We talk a lot about sort of risk assessment and sort of helping providers make a decision about whether a kid really needs to go to the emergency room, or can we do a safety plan, give them resources. not every kid needs to go to the emergency room, and given the state of our emergency rooms right now, we don't really want to be sending kids there unless they really need to be there. So we can talk those things through with you. And again, the notes from that would be emailed to you within 2 days as well. Care navigation. So I think care navigation is one that providers seem to be less familiar with, but that I think could really help you all. And it's one that ideally and hopefully could take some things off of your plate. You know, the consult line, talking to myself or a psychiatrist, that requires more work for you, right? It takes time and effort and energy. So you're adding things to your plate. Hopefully it's helpful, but it still is adding things to what you've already got going on. Our care navigation services, our care navigators, I will tell you, are the only providers within VMAP who are able to communicate directly with families. So for the consult line, like I'm only able to consult with you, and then you would go back to the patient and implement whatever we discussed. I'm not able to talk with the family and conduct a risk assessment. I'm not able to do a safety plan with the family. It would be you and I doing a consultation around that. Our care navigators, if you want them to, would be able to reach out to families and provide services, or a list of services. So for care navigation, if you call the consult line, you would let us know that you had a patient who really needed to find a cognitive behavioral therapist for anxiety. And so you could let us know that and say that you need help finding that for this family. And then I would ask you, okay, do you want our care navigator to send that information to you, and you as their provider give that? Or would you like for our care navigator to reach out to the family and help them with that process? And then our care navigator would then reach out to the family, sort of maybe talk about what the family really is hoping for. You know, do they want telemedicine? Do they want in-person services? What's doable for them in terms of distance and a drive? And sort of problem solve and talk about what they're wanting. Based on that conversation, the care navigator would then provide 2 or 3 targeted referrals for that problem, right? We don't want to overwhelm families and give them a list of 15 providers to call. That's completely overwhelming. And so our goal is to really find 2 to 3 decent options for the family. Again, there are barriers to this that we're facing too, but 2 or 3 options that the family could reach out to get services going. And then we would sort of give them an idea of what to expect. Our goal is for our care navigators to have an idea of the landscape of things and what wait lists are looking like at these places, to be able to discuss that with the family. Then the care navigator follows up with the family every 2 weeks, just to sort of problem solve. You know, did they call? I think sometimes just having someone calling the family back to remind them, and families are often like, oh yeah, I was supposed to do that, whoops. And just having someone reminding them of that, or if they tried to call and they ran into any barriers, the care navigator is really there just to help the family figure that out and problem solve as feasible. And then the care navigator would also be emailing their updates to you as their provider. That way you're sort of aware of what's been recommended. You can follow up with the family as you want to say, you know, oh, I know that so-and-so gave you referrals for these places. Has that worked out? How's that been going? So everyone's sort of on the same page with what's going on. I mentioned that levels of care is a frequent referral question, or maybe it's not a referral question that providers come in with, but it's one that ends up happening sort of naturally. I think oftentimes we think of mental health treatment and we think inpatient, weekly outpatient, and those are like the 2 things that we think of. And keep in mind, there are many things between that, right? There are many sort of these middle levels that we can consider and think about. Now, access to these, of course, depends a lot on where you are, wait lists, what's available, but there are other options than inpatient and weekly talk therapy or weekly evidence-based treatment. So this is just sort of a a diagram looking at sort of all of the options. You all do not need to know this, you don't need to memorize this, you just need to know somebody who does know this, so that you can talk through it with them, and they can say, oh, it actually sounds like this patient might really benefit from something like an intensive outpatient program, or hey, I think this family would really benefit from intensive in-home services, right? So just being able to have access to someone who knows this and is able to sort of guide you and give some recommendations. This is all very confusing. Even as a mental health provider, sometimes I'm like, okay, wait, what is intensive outpatient again? Like, what are the qualifications for that? Who does that? And so I think a lot of our care navigators are really sort of up to speed on some of this stuff and can help guide you in that way too. So again, I'm not going to go through all of this because you don't need to know it, but it is in the slides, so you've got that. If you're ever curious about it and just want sort of a quick blurb about what that is, I'm including that here. So again, VMAP was really designed and out there for primary care providers, right? But services are also available, and we encourage subspecialists to use VMAP as well. Depending on what, as a subspecialist, your role is with the patient, you might have differing needs of what you might want. Like, you may not be doing med management for a patient, maybe you are. But maybe you need more of the care navigation services, or maybe, I know a lot of subspecialty clinics, I know endocrinology, when I was at OU, they were doing depression screenings and screening for suicide. And so if you're doing that and you get a positive screen and, oh gosh, now what? I need this patient to find services. Call VMAP, get care navigation for this family. Send them back to their primary care provider as well. You know, maybe in the meantime, we can get care navigation services going for this family and try to get them on a wait list for services. Or we can sort of walk you through, does this patient need to go to the emergency room? Do they need to go to the community service board? But that's something that can be of value to subspecialty providers as well. Again, treatment considerations, you know, kids facing chronic illness, are facing many mental health concerns as well, right? Like, it is a huge stressor for these kids and families. And so talking through with the provider, like, what service would this kid benefit from? What are important things to consider when referring them to a mental health provider? Not every mental health provider is trained and equipped to treat kids with chronic illness, and they may not have the knowledge of diabetes or whatever it is that a patient would really benefit from. So call VMAP. We can find a provider who knows that, or at least would be providing evidence-based services for a kid. And so again, like, even if you're not in primary care, you can call us, and we're available for subspecialists, primary care providers, including pediatricians, but nurse practitioners, PAs, full gamut. If you're sort of a prescribing provider, we can help you. And so just keep that in mind too. An exciting thing with VMAP is that the guidebook was recently published and is available online, free of charge, universally there for everyone. Here is the website for that, but the guidebook is really a comprehensive resource. It talks about what is VMAP, but also provides sort of a different chapter or a care guide for all types of mental health concerns. So there's a chapter or a care guide for depression, for anxiety, ADHD, a number of things. And within each of those care guides, there are flow charts, there are recommendations for what screenings you can use, there are recommendations for what is evidence-based treatment for this presenting problem, what should families be asking for and receiving when it comes to treatment, medication, what are medications to consider, what are the guidelines for that. It really just is a comprehensive resource that I think will be really valuable for providers. Please register for the consult line. A couple reasons for that. I think one reason is because then when you do call us, we'll ask you fewer questions, and that's nice, to not have to give your NPI every single time you call us. Register. Also, like, we're state funded, right? And so if people aren't using the service, they're not going to have a lot of incentive to continue funding. And this service is really needed. So just register. Give the consult line a try. I've talked with providers at UVA who are like, well, I'm just like nervous to call for the first time. I don't really know what to expect. I have a kid who I think might be helpful to call on, but I just don't know. Just do it. Just call. I promise it's pretty painless. It does take a little bit of your time, but hopefully it's helpful and worth that extra time that it takes. So you can go to the website to register, vmap.org. You just enter your information, and you're registered. It's not a grueling process to do that. Here is the number for the consult line. I put some handouts and pins and clips and things back there. Just keep that handy so you can sort of see that and remind yourself, oh yeah, that thing exists. I can call them. The consult line says Monday through Friday, 9 to 5, but usually the last call is taken at like 4:30. Usually stop answering at about 4:30, just because if we're answering at 4:45, our psychiatrists, other providers are not going to be able to get to that day, so they usually roll over to the next day. So just be aware of that. Also keep in mind, maybe it's after hours and you have a thought of, oh, I've got this patient coming tomorrow, or I saw this patient today. I want to talk to someone about that. You can go to the website and put in an online consult and request a time for us to call you back. So you can just put in some information, and then one of us would give you a call whenever you tell us to sort of start the intake process the following day or whenever. So that's an option as well. And so I know I have to ask you all questions as part of this. So question 1, barriers to children's mental health care include which of the following?
D.
Yes. D. All of the above, all of the barriers. True integrated care occurs when an interdisciplinary team works together in which of these?
Hey.
Yes, everyone's together. And question 3, who can call the VMAP consult line?
B.
Yes, families and patients cannot call the consult line, only providers can. Again, if you're wanting care navigation, the care navigator can reach out to the family at your request, but you would be the one that sort of facilitates that process. We do ask, even if you're just doing a consult, but especially if you're doing care navigation, let the family know that you're doing this. Give them a heads up that, hey, I'm going to talk with this person, this mental health provider with VMAP, and you're going to be getting a call from them to sort of help you find services. Just give them a heads up. That way when we call, they're not totally confused and like, huh, how'd you get my information? So just let them know. I'm happy to take questions now. Also, I will stay a little later and answer any questions that people have. Also, please feel free to email me if you have questions or feedback. If you use the consult line and have a suggestion, and it can be positive or areas of improvement feedback. But if it's positive, I can pass that along to the appropriate people. They can pass that along, and I think that further lets our funders know that, hey, this is helpful and a good use of funds, and we should keep doing this. I'll also sort of briefly mention recently, exciting news in VMAP is that additional funding was approved. I think it was 1.3 million, is that right?
Something like that.
Something like that, for sort of focusing on early childhood and how VMAP can really sort of help support the littles, the 0 to 5. How can we sort of help with that? Because I know as a provider within our developmental and behavioral division, I know our wait list for like an autism evaluation is close to a year, if not longer. So that's a real issue too. So that's exciting that there's the money dedicated for that. What questions do you have for me about VMAP?
First off, I just want to thank you. This is a great program, and thank you for coming in person today. It's great. Right at the very end of your talk, you said something that sparked my interest. You mentioned telling the parent they might get a call. How does the system work from a HIPAA standpoint? I mean, so are we supposed to tell the parent that we're calling someone and discussing the case? How does that work?
have to from like an ethical standpoint, because it falls under the bridge of consultation, right? And you're allowed to consult with whoever about a case. We encourage it, and I think it's ethically kind of nice for the family to be aware of that. It's not required, it doesn't break like a HIPAA regulation if you don't notify the family. I think it just makes things run a little smoother. And it's nice for the family to know that you're gonna be talking to someone about this. I think that's especially important for the care navigation piece, but for consultation as well. But since it falls under consultation.
I mean, if we give them the parent's number to call, you are giving information out to a third party.
Sure.
So I'm just curious, has that ever been raised as a concern?
It has, and I think that's been sort of a barrier, I think, in the beginning of some kind of getting people on board with this, is how is this information being stored, where's it going, what are the HIPAA considerations? And so, again, for care navigation, if we're giving the families information, it is important that you say, hey, is it okay if I do this? I think some providers may prefer just not to do that and say, okay, the care navigator can reach out to me and give me the information, and I will deliver that to the family. If it's a family that you feel would accept the information coming from you, or maybe a little bit resistant to the information, we have the option of just giving that to you and you passing that on as well.
I have a question, kind of following up with what Dawn said. But if you're just calling, you don't have to give personal information, right? You say, I have a 14-year-old, da-da-da, and then whatever's emailed back, unless it's a care navigator that you're, of course, okay. I want to clarify.
Well, when we're getting information, we are going to get the patient's name, their date of birth. We are collecting that information, their insurance. When we email, that's de-identified, so we're not emailing you with the patient's name, and that's not going through email. But we are collecting that, and then the good thing with that is also when you call back on the same patient, there is a record of that. But so you don't have to rehash and give us all the information again, but that information is being stored in a database.
Okay.
And all of this is HIPAA compliant. This has been passed through tons of levels of legal review through the state. So I don't think we need to worry about HIPAA concerns for it. It's under the umbrella of treatment, which is something that is specifically in the HIPAA regs, that we can share information related to treatment, payment, and I forget the third thing now. But we're good.
Scrutinized and looked at, and
I had one more follow-up with that one. So in the different areas, the Southwest, are you manning all of those areas, or the Southwest, for example, Mount Rogers CSB has a psychologist, a navigator, or a licensed mental health provider, and a psychiatrist that mans that area?
Mm-hmm. Every hub has their own team.
Okay.
And ideally, when you call, you would get your team, because I think it's helpful to talk with someone who knows the area and knows the region. Mm-hmm. We do help each other out a little bit, and I think especially for the Western region right now, as we're getting up and going, like I'm really the only one manning the consult line right now, and I'm half-time. Mm-hmm. And so you may get someone, especially right now, the Southwestern hub is one helping us out right now. And a lot of them are kind of familiar with sort of this region too, but there's a chance you would get that team, or if one of us is out on vacation, we sort of help each other cover. But for the most part, you should be getting connected with your hub team. Like when you call the consult line, it'll ask you, which region are you calling from? And you'll hit 4 for the Western region. It'll direct you to my personal cell phone. And it'll kind of do it that way. If I'm not available, it goes to the next person. Mm-hmm. But every sort of region has their own hub that they operate out of. Mm-hmm. And I will say, I think one of the good things that will be coming with the care navigation piece that I'm looking forward to, and the other regions are getting this going as well, in the next few months we'll be sort of starting care navigation regional advisory groups, where it'll be the care navigators for that region, myself as the LMHP, and then sort of community mental health providers who are wanting to be part of that. And so we'll meet every few months to kind of talk about the landscape of things and, okay, what are you guys offering right now? What's the wait list? What barriers are you running into? And so everyone will kind of be, from a mental health world, kind of talking together about what's helpful for care navigation too, which will be really nice.
Thank you.
So I did want to take the opportunity to put a plug in for the guidebook. The guidebook is going to come out in tomorrow's Friday email from the department to everyone. And for those of us in primary care, the reality is you take a pay cut a little bit when you provide this care because they're longer visits and the reimbursement isn't quite the same. So I will also direct your attention to the billing chapter. If you have problems with it, let me know. I wrote it, so please tell me. But like the AAP table that a lot of us are familiar with for medical decision-making, there's a similar table for how you can apply these rules to psychiatric care or mental health care. And that's really important because unless we bill for this work, we can't afford to do this work. And, it's key. And billing is almost advocacy if you talk to the AAP level. You have to bill appropriately in order for us to demonstrate that we can provide these services. On a national level and a state level, VMAP is advocating for something that exists in Canada, which is enhanced reimbursement for those providers or practitioners who are doing mental health work, who have received additional training to do mental health work. So in Canada, in some of the provinces, you get a bump if you have done a program like REACH for your mental health care. And that's really important in the workforce expansion aspect. So with that, I'd like to thank Dr. Anderson for providing this talk and invite folks to explore how you can use VMAP. I know I had questions from subspecialists during my first talk about what can we do as subspecialists. Well, you can take advantage of that early intervention. So you have a kid who's got mild depression, who has diabetes, or who has cancer, get care navigation, get interventions for them because most of them might not require meds. They require support. And that is something that you absolutely can do. We've had oncologists take REACH because the reality is they're providing primary care for their patients. So just an advocacy for using the services, no matter where you are and who you're treating. So thank you very much.